So, Kevin, you wrote a great newsletter again this weekend. I thought we'd start the morning by kind of recapping that. You opened up with an interview with Arkell. Can you talk a little bit about how you've come to know Arkell?
Yeah, Arkell and I actually are or were on the board of a non-for-profit in Minnesota together called Caring Bridge. Awesome little organization that helps people tell their stories as they're going through health journeys. So I got to know her through that. She's had a podcast going for a while, and she last year did a podcast episode talking about prior auths. She was formerly chief medical officer at United Healthcare back in the late 90s. And in this episode, she and another former chief medical officer of United were talking about how back in the day, United made the decision to remove all prior auths from their plans. So I was listening to that podcast episode, and over the course of 2025, obviously we've had a lot of conversation about prior auths, the CMMI model, Wiser, being kind of front and center in that conversation. And to me, it was high time to reach out to Arkell to see what they learned from the experience in the 90s, what they went through, why they did it. And that was kind of the impetus of conversation with Arkell.
Yeah, I thought it was a really interesting and in many ways counterintuitive conversation. I loved the video that she shared, the
It
PR
is
hit.
like peak 90s vibes, right? I mean, it is a great time capsule of what that era was like.
Yeah. It brought me right back, and I'm so happy that we have a recording of that for um, for the time capsule. One of the things that I thought was really interesting about the interview was, she mentioned state regulators, employers got really upset at
Mm-hmm.
United and I was wondering, like, why, what is the impetus basically for them getting upset about getting rid of prior auth?
So my interpretation of it, and all the caveats, I wasn't there at the time. I wasn't in those conversations. So this is a little bit of telephone from me hearing it from Arkell and then recounting it. But the narrative that makes sense to me and the way I heard it from Arkell was essentially that these states and employers came to expect this behavior of managed care organizations because, in theory, it's how they managed cost. And oftentimes, states and employers are actually the payer and the pot of money that an organization like United is helping to dole out. So if you're an employer and you're saying, hey, I've contracted with you, Martin, to help manage my healthcare spend, and then all of a sudden, you, Martin, are saying, oh, we're not doing this thing that helps manage healthcare spend. You can see why they might be a little peeved that, it's kind of a you had one job and now you're saying publicly and on Good America that you're not doing it. And Bill Clinton's out there talking about how great it is that you're not doing it. And the AMA seems to like it too, because they're also talking about how great it is. So Arkell mentioned they had to go around to various states and talk to employers about why they were doing it. And she made a pretty interesting case in my mind that by removing these prior auths, you actually end up saving money as a plan. And apparently they saw this in a pilot rollout with a few plans and decided to roll out nationally. And uh, that was kind of the impetus of the pushback. It was very counterintuitive to me. Like I wouldn't have expected, particularly given the climate today and what we see from Congress people talking about railing against Wiser and whatnot. I would have thought that everybody would have been like, "Great, no more prior auths, perfect," But
Yeah,
it's never that simple.
I I thought it was funny when she talked about getting hauled in front of various state attorneys general and
Yeah,
like them
for sure.
admonishing her for, and you're like, yeah, like it's impossible to imagine someone, an elected official today, being like, if you get rid of prior auth, you're gonna have to come talk to me because we got
Right.
some big issues with that.
Yeah. I it's very counterintuitive to me. But also as another like our theme of trade-offs that we often talk about in this industry. It shows why it's so hard to drive change.
Yeah. So they didn't just like eliminate prior auths and say, cross their fingers and say, let's hope. this works out. They replaced
Hmm.
prior auths with a prior notification system, basically saying like let's let the doctor or let the health plan know in advance when a big ticket item is coming up and
Yep.
care management.
Yep.
And listening to that, I was like, oh, like this is kind of similar to alignment strategy and what alignment
Hmm.
talks about. And alignment's just been crushing it lately. And so I thought that was like a cool sort of through line through the last couple decades is that like, yeah, if you do good care management.
Yeah, I did too. And logically, it makes sense to me. Like I asked her the question in the interview. Um, GLP-1s come up a lot in conversation today, obviously, right? And employers are trying to figure out how do they both provide access to GLP-1s while reducing the cost of their employee population, or what they're spending for their employees. And there's a lot of startups that are coming in and saying, hey, we will help you with care management. And as long as employees are doing these lifestyle changes, they'll get covered access to these drugs in some iteration of it, right? And to me, I'm like, well, that feels like a flavor of saying, okay, we're going to limit access to care to reduce the cost of care, which fundamentally is what prior authorizations are a vehicle to do too, right? Um, Her point back, and this ties back to that care management point, was they're fundamentally different because it's not just a denial that the prayer is saying, like, no, you can't access this and not giving you any other tools. It is saying, hey, here's a path forward. Here's a type of care you can receive. And if you do these things, you will get access to this. And a point, as I heard it, is that changes the framing of how it's received, how it works in the industry. And I get that. I mean, it makes sense to me. I don't know that I am necessarily as philosophically opposed to prior auths. Like Wiser being a really good example of that. Like I look at that and I go, I don't. I think we've gone overboard on how widespread prior auths are, but they seem like they've got a use, and particularly um, in some areas where they seem at high risk for overuse, negative outcomes, etc. But yeah, as I think about like if you're in alignment health and you think about implementing these sorts of programs, it makes sense to me that they should work, right? We got into a Slack conversation this week about this with a community member about how much uh, process you have to end up putting in place to make prior auths go. And at the end of the day, I think we were talking about denying MRIs or something like that. If you deny and you just count the savings from that denial of care, and then you build up a team and infrastructure designed to capture the ROI off of those denials of care, you still end up increasing costs elsewhere because it's not like that person just like doesn't get it and then doesn't go do anything else. And his general point was, the ROI that tends to get baked into these things isn't actually all that real. And it's like, oh, okay, yeah, I haven't dug into the numbers enough to see, but it's at least a theory that seems plausible to me, right?
Yeah. Yeah, another theme we sometimes talk about is that there's a lot of sort of like visionary talk in healthcare, but a lot of this stuff comes down to like being a really good operator. And
Mm-hmm.
alignment is sort of like the prototypical example of like a very good operator to me.
Mm-hmm.
And yeah, you can do less prior auths if you have really good care management and really solid, strong lines of communication with your patients. That's hard to
Mm-hmm.
do, and it's not cheap. And
Totally.
but
Yes.
if you do it enough, you can make 3 to 4% profit margins on.
Yes. Ultimately, it seems like it is all about how you drive alignment between the payer and the provider and the patient, and you reduce friction in a way uh, that is most productive.
Yeah,
And prior auths can be used in some certain circumstances. Care management can be the same, but at the end of the day, to your point, like it's about how you implement it thoughtfully as part of the overall relationship between these entities, which is very fraught and challenging, as we all know, and kind of a never-ending game of whack-a-mole.
Yeah. But the conversation did give me, I think, like cause for optimism that, that we see that there are people who are doing this successfully today,
For sure.
and that United was able to kind of had the organizational sort of have to pull this off in the 90s.
Yes,
And so, yeah,
totally.
I thought it was
Yep,
cool.
for sure. I did too. I mean, it's one of those examples of, I mean, clearly here we are 25 years later and prior auths have swung back and are overused. And so you know, it clearly didn't change the industry forever. They're back. But it's a cool effort and I applaud the effort and it's fun learning from it.
Yeah.
So,
Also in the newsletter this week, there were a couple, I thought it might be fun to do a little roundup of what happened in AI this
oh
weekend. And
boy,
so you
lots of
had
things.
lots of things. I wanted to start with that Menlo Ventures survey on healthcare winning the AI race
Yep.
and kind of get your reflections on that.
The chart I included in the newsletter I thought was a interesting one that I mean maybe I was seeking confirmatory data, but there's the general case that everybody seems to be making these days, which is that health systems have outpaced payers in terms of their adoption of AI. That is part of why we see in earnings calls a differential performance between health systems doing well, seemingly beating and raising guidance every quarter in 2025, and payers who are not doing quite as well. And we've heard payers early this year talking about how providers are using ambient AI to listen in on doctors' visits and code at a higher intensity, which is increasing costs and so on and so forth. So the chart I thought was most interesting was a chart looking at adoption of, I think it was of AI tools. And there's a pretty significant jump for healthcare leaders. And I think so. Survey of 700 leaders done by Morning Consult, I believe, with Menlo Ventures across industries. And healthcare as a whole jumped from like 8-ish% September 2024 to 22% today. But health systems jumped to 27%, while payers were down at 14%. Now, like, they don't show the charts for health systems and payers, which it would have been great to see, like, how that curve grew over time. But to me, it is very indicative of that general narrative, right? We've seen health systems adopting these tools faster than payers. They are benefiting from them. So I also think it'll be interesting to see how payers respond to all of this over the next year. Like I would be surprised if payers continue to lag behind, which I think is interesting to ponder.
I thought it was a cool survey because it asked about paid AI licenses. So this wasn't
Yeah.
just pilots or anything like that. This was like actual, in
Uh-huh.
the
They're
field.
using the tool. Yep.
They're using the tool and they're paying for the tool. Um,
Yep.
but yes, based on the payer and hospital operator, I was 0% surprised at that lag.
For
And it'd
sure.
be interesting to look at this again. I believe you've described the sort of AI race as like a zero-sum game, that at some point when they catch up to each other, we're going to be back at a stasis. But until then, whoever has the advantage is going to be extracting more value.
Yeah, for sure. I've got one of my many blog posts that I'm like halfway through is about how I think all of this is a Nash equilibrium where we're in this like very long game negotiation battle between payers and providers and like this plays out over years and decades and we are seeing the responses to negotiating battles, right? Payers were denying more care as we talked about prior auths the last few years, whatnot, that hit provider financials. Providers are now in this stanza of the negotiation implementing these things. We can and should expect to see payers to respond to that in the next 2 to 3 years. That will help payer financials. But like at the end of the day, this is all a back and forth of a negotiation that each is like doing, they're finding their local maxima in the negotiation, right? Like uh so it'll be
Yeah.
interesting to see where it goes from here.
Another thing that happened this week in AI is that Open Evidence hoovered up some more money.
A ton of money. They raised what? It was 200 million bucks again. This is 3 months after they raised $210 million. The valuation 3 months ago was 3.5 billion. Today it's 6 billion. The usage stats are insane to me. They included in this one that there were 15 million clinical consults this month, which is up from 8.5 million back in July, which is it's just wild for me to think about how it's a really big number, right? Is the short way of putting it. But so they're gaining adoption in the space. This whole like clinical decision support frontier feels like the next hot area in healthcare AI. And logically, to me, as a use case, it makes a ton of sense. It also will be interesting to see. So, Open Evidence in this news coverage talked about how they've now started their advertising revenue model, which sounds a lot like a Google-ish advertising revenue model. It is up to 50 million, and they didn't say if it was like ARR. I would assume it's like an ARR 50 million number. Um, that's up from 0 3 months ago. So clearly, the revenue stream is picking up. They expect it to be at 100 million within a year, which I mean, kind of seems like that's gonna grow very, very quickly, and good for them.
Two comps that I'm watching for open evidence are one, Doximity, which is the sort of
For
original,
sure.
mostly advertiser revenue driver
Yep.
for doctors. And doctors are a really valuable group. So, like, that makes sense that you would want advertising dollars, not just for life sciences stuff, but like you got
Yep.
when you have doctors, you have a high willingness to pay and nice customers. So that's a valuable segment. The other one I'm thinking about is GoodRx. So for a very long time, the conventional wisdom has been you have to be in the workflow, otherwise your thing is not going to get used. And
Yep.
GoodRx was the first sort of counterexample to that, where they had really good stats on doctors were going out of their workflow to look at GoodRx to help their patients find pricing.
Hmm.
Um, because it was such a hassle to have to get phone calls back and to have to update prescriptions. And it's interesting to see open evidence with this kind of growth all happening outside of an ERR excuse me, an EHR. That this is
Yep.
growth that's happening,
For sure.
and you're doing the thing that people have been saying for years doctors won't do, which is leave the EHR to do something.
Yeah. I think that is one of those rules that it's true till it isn't, like I remember from my provider days where um you'd be talking to legal teams at health systems, and I'd ask, I was like, do you know how often providers are texting each other things about patients inside the system? And they'd be like, do not talk to me about that, because uh they don't want to know about the risk associated with that. But like clearly it's happened. Like if you talk to providers, they are doing that. They're sending photos back and forth to each other. Like there's a I it logically makes sense to me why things need to fit in the workflow. And then it also logically makes sense to me why, when the experience is good enough, they don't need to fit into the workflow, which is just that it's easier, it's more convenient, there's value to it. And so
Yeah.
good for open for evidence and figuring that out. GoodRx, I think, is a good example of that too. I the I was talking to somebody who mentioned that feels like, so up to date back in like early 2000s when it started taking off, basically took the medical textbooks and digitized them, right? So Walters Kluwer, all these other organizations that had the textbook versions, up to date came along and turned it into an electronic version of that and took off. And it wasn't long before those old school institutions started making their own product of it, which made UpToDate's run not meaningful, not less meaningful, I should say, but like it capped the growth of an org like that because there's all of a sudden competition. And in many ways, it seems like open evidence is doing the same thing here, where it's taking advantage of a new technology to make information more accessible in a different way to docs, which is great. And the industry is going to catch up to them pretty soon, right? Like I would expect that everybody else, open evidence is already doing, or open or up to date is already doing stuff here. So like I'll be curious to see what this space looks like in a year or two, you know?
Yeah, and I think the sort of outcome will be similar in that Up to Date
Yeah,
ended up a Wolters Kluwer property, correct?
right. Yeah.
And Elsevier and Open Evidence have a partnership from back in the day. And if I
Yep.
think it's like either Open Evidence continues their meteoric rise and folds in Elsevier or First Data Bank or something like that, or AI
Hmm.
valuations get cut because people are like, well, I this is insane, and then it ends up an Elsevier property or something like that.
Yep.
Um, last AI highlight from the week was Optum Real. So going back to United Health and their, could you talk a little bit about what Optum Real is and what they're doing with Alina in
So
your backyard?
in my backyard, both former employers of mine. There's not a ton of detail out on this one. Conceptually, what it seems like they're doing is new claims adjudication type system that makes the process easier, more integrated, reduces pain points between the payer and provider on that front. Conceptually, that is a seeming no-brainer on use of AI and tooling between providers and payers. I think they mentioned they're targeting cardiology and radiology first as kind of they're rolling out the platform. So to me, it's one of those interesting things to hear about. I've learned in covering the space now for a while. It's always interesting to see if there's a second news release about initiatives like this, right? Because the first one that goes out about the pilot getting started is always, hey, there's this groundbreaking new thing we're doing. And then there's a high percentage of those that never actually make it to the second news release of, hey, here's how the first one went, and we're scaling it up. So it'll be interesting to watch for that. But to me, it's kind of going back to the Nash equilibrium zero sum game of payer provider negotiations. It's an example of where there's opportunity there to do better, reduce friction between these organizations. We'll see how it materializes. What was your
Yeah.
reaction?
Well, this sort of goes back to the Menlo Ventures survey, which is that
Hmm.
it's kind of hard to imagine a field that has more applications for LLMs and the current state of AI than healthcare, and that some of these things, like we have these interoperability problems that can be solved by a sort of like a large language model transforming, A to B.
Yep.
We have like huge amounts of numbers and text and huge corpuses of data that we can sort of use to refine. And so I like conceptually it makes sense. Like you will be, sort of waiting for the second press release. But I thought it was a kind of a good data point on how we escape the sort of the ones or the prisoner's dilemma that we're in right now, where
Hmm.
we're not maximizing value for the system. All right, last thing I wanted to chat about today was the New England Journal of Medicine article about concierge medicine, one of my favorite
You like that
topics.
article, huh? Yes.
I sure did. So I wanted to start off by saying when I think about concierge medicine, I sort of in my head think of concierge medicine the same as I think of like direct primary care. Do you lump those together in the same category, or would you? Is A a subset
I
of B?
so I think there's my version of things, and then there's, I think, the kind of general conversation that happens about this stuff, right? Which is, I think there's a Venn diagram. I think there is overlap between the two concepts, but I think there is a difference between the two concepts as well, which largely is in uh, the connotation of concierge care is that you get concierge access to a doc that you want access to, which means you are paying a premium for that access, right? So groups like the article I think talked about private medical. Um, Organizations like that at the very high end are tens of thousands to hundreds of thousands a year for access to really high end services. To me, that is concierge, which maybe is a subset of DPC, but I think of it like as its own thing with overlap to DPC, which I think of as concierge care for the masses. Conceptually, it's a lower price point. It's in the hundreds of dollars a year to maybe low thousands, but it is much more about a monthly membership model for access to primary care. That is how I think about them. Do you have what's your mental model?
Yeah, I think that it's a lot about price point and
Yeah.
marketing and the experience. I think one thing that's interesting to me is that One Medical was sort of a concierge-esque branding, positioning, but not
Hmm.
price point. I don't
Hmm.
know what it was when it started, but these days, if you have Amazon Prime, I think it's like $200.
Yep.
And one of the things I've been tracking recently is like One Medical, but for Medicaid, kids on Medicaid, right? That this idea
Hmm.
that you have concierge style access, maybe not to a doctor, but to a care coordinator or something like that, 24 hours a day, because kids sometimes get sick when not between 9 and 5. And to me, being the eternal optimist, it's like one of those cases where technology has really enabled
Hmm.
scale in a way that I think is very hard. And so you can price discriminate, and if there's people willing to pay you $100,000 a year for your concierge practice, and you have like cucumber water in the lobby, and you do house visits or whatever it is, then more power to you. But also, I think that there's like concierge-esque stuff that can happen down the payer scale, even to Medicaid patients, which I think is really cool. Um,
Hmm.
it does raise some questions, though, and I thought that this New England Journal of Medicine article did a really good job of raising questions. One of them is just about
Yep.
price, right? And so there was a quote that they did some patient matching. Important to mention that this was just one concierge medical group, but there was they did the patient matching on age and medical conditions, and they found that spend was 30 to 50% higher for the patients who switched to concierge practices, but there was no difference in mortality. So that doesn't surprise me at all. But if you have the means to go to a concierge doctor, you probably are not super
Right.
high acuity.
Yep.
And you're getting more attention. And so obviously it's going to cost more money for you.
For sure. It is the go back to the that iron triangle conversation we were having the other week. It is that at play, right? You are increasing access to a high quality doc that is going to cost a lot of money. You are increasing cost to the system. People are choosing to do that in this case, so it's out of pocket. It's, hey, I've got $100,000 to spare. I am concerned about my longevity. I'm gonna go pay for that. Like, cool. Like that is a rational choice that you can make as an individual, and I support folks making. Like, if you want access to that doc and you want to pay them to go do that, great. Like that seems like a useful thing. But I
Yeah.
like to go back to your point on the math. Like I don't think that I don't think that reduces healthcare costs in this country.
Yeah.
And I don't think that's a like I don't know that that's a controversial statement. I guess
Yeah.
maybe, but I don't know.
Yeah, I think the other piece of it that I found really compelling about this article was the first derivative of that, which is that you are increasing costs because you're taking someone who has the Jewel Mullen, who's an associate dean for health equity at Dell Medical School, says, if you're taking this PCP, their panel is shrinking from thousands of patients to hundreds of patients,
Yeah,
and if we don't have more PCPs, then the first derivative of that making healthcare expensive for that one person is also
right.
worsening access and making starving the system of supply for all of the other people.
Yep.
And so that I think to me is one of the more frustrating aspects of this is that it is a that not that a doctor would choose to do concierge medicine, which like
Mhm.
we live in America and I love small scrappy entrepreneurs and DPC stuff, but like that we can't seem to just like train more doctors. And so a handful
Right.
of or that the experience of being a PCP is so bad that people are like, well, I'm just gonna go to concierge or,
For
something like
sure. Yeah. I mean, to me, it is another, I think that's a relatively hot topic of uh, like what is the impact of DPC models concierge on the entire population, right? And to me, it's a question of what is your starting point for that conversation. Like there's a lot of primary care providers who feel underpaid and burnt out by the existing infrastructure. And I think it's a very natural thing for them to say, hey, I can go make a better living, I think, in this concierge type model. And I don't have to deal with all the BS of the existing system and insurance and the administration of value-based care and whatnot. Like there's an appealing simplicity to that. Now, I will be curious to see what that looks like a decade from now. As we talked about, there's a group in here in my neck of the woods too that 10 years ago went into concierge care. It had 6 docs at the time, I think, put out some press about how they were really excited about it. And you fast forward to today, and that practice has 1 doc left, and it's back in fee for service medicine. And the website is all about how we talked about this in Slack last year, I think. Website is about how fee for service medicine is actually really pretty straightforward at the end of the day, right? Like, can you do cash pay fee for service and not have to deal with insurance, but just get paid a certain amount for doing a certain thing? And there's an appeal to that. And so to me, anecdotes like that, I think highlight kind of where this conversation's going in my head. But certainly there is a lot of interest in the direct primary care model on the whole, which I get. I get. Yeah. To me, there's an interesting like I'm doing the math. So if we have 350 million people in the country and a DPC model costs what, $1,000 a year, um, you're looking at a to give everybody DPC access, you would be at 350 billion in additional costs for the healthcare infrastructure in this country, right? And so if you're telling me what is healthcare in this country, it's like 5 trillion today.
yeah.
Um, would you make the trade-off of increasing healthcare costs in this country by 350 billion? So sub 10% of healthcare costs to give everybody access to a DPC-esque primary care provider. And Matthew Holt kind of makes a similar case in his healthcare blog last week. Like I think that is way oversimplified. I don't actually think it would actually work out for a million different reasons, but it's an interesting thought experiment to me in this like iron triangle of cost, quality, access. Like it might actually be worth it as a trade-off for us to increase healthcare costs as a percent of GDP to get better access and better quality for primary care versus what we have today. Um, Bending the cost curve, as you talked about last week with the ACA, while I totally understand it, might not actually be that great of a thing when people want more high quality access to healthcare services in this country,
Yeah. Just for an
right?
order of magnitude, $350 billion, a lot of money.
Uh-huh.
I'm not, but if you let the ACA tax credits expire and you capped the tax exclusion for employer-sponsored insurance,
Yep.
you could pay for that and then some. You could actually pay the doctors a little bit more. That's like 500 billion a year. So like
Yeah.
I maybe it's worth a
Yeah.
try.
There's always money in the banana stand, Martin. Um, yeah, I don't know. To me, like the other interesting, I talk with friends building, new primary care companies and whatnot. And like go back to that one medical example of Are they DPC? Are they concierge care? A lot of this comes back to price points and how much you can pay providers, i.e., like if you're offering a DPC model at a low price point and you cannot pay top salary for provider, you're not going to get the best provider because it's a competitive job market. There's a shortage of these providers, and they are gonna tend to the highest paying job opportunities that they have, right? And so if you're paying market median or below, you're going to lose those top docs to higher paying places, right? And so to me, it's a like when we talk about concierge, you think you're getting access to the top quality. That is what you want out of that, right? Like I want a good doc who I trust who is there all the time. I don't want access to a random clinician that I don't know via video visit who changes every time or whatever else. And I think there is an underlying reality in these models of like, you need to pay good docs well. You need to incentivize them to partake in these models so that they want to work in these models. And if you're paying top of market salaries for docs, you are not going to be the cheap, low cost solution like that. Like, I don't know, it's just not how the world works. And so,
There is a third option, Kevin, which is
what's the third option?
you can get venture capital investors to subsidize your losses
Sure. Yes.
for a number of
100%.
years, and then
Yes.
Amazon can buy your company.
Yes. Yes. Martin, I've got a great business proposition to you. You can pay me 50 cents for a service that actually costs $1 because I'm going to subsidize the 50-cent loss with venture funding to pay for that. I say that cheekily, but in many ways, that is, I think, the reality of the venture-backed care model space over the past however many years now of yeah, like if you are allowed to burn a crap load of money, you can figure out how to do a better care model, which is you hire better people, you have more people on a care team putting their arms around folks, which is great. Like that is an awesome thing. But like we've lost sight of the fact that like the only way that is paid for is by VCs burning through cash to support it. When an organization buys them that wants to turn it profitable, because at the end of the day, they need to, what happens? You revert back to the norm and you've got a care model like any other organization that's trying to make money off of it. And you lose kind of that secret sauce. Anyways, I could go
Yeah.
on for a while about that one. But um, these are laws of gravity, I think, in healthcare land that
Yeah.
um, you know, how they go. So
Yeah.
Martin, tell me about earnings this week. Speaking of large companies buying small loss-making ones, who's telling us how they're doing in terms of their profits?
Yeah, so we got a busy earnings week, so I'm just and since we're meeting back here tomorrow at the same time to give folks an update, I'm just going to go over tomorrow's earnings. So we got United Health Group, their revenue estimate from the analysts is 113 billion, up 12% year over year. EBITDA and earnings per share, not the estimates are down 46 and 60% year over year. So that'll be interesting to see. UHS, the hospital operator, who is a hospital operator in my backyard, and so I'll be watching this one closely. Report tomorrow morning as well. They're looking at 4 point. The analysts are looking for 4.4 billion, 10 up 10% year over year, 16% up 16% year over year for EBITDA. Going back to what we were talking about earlier, it's you have the big insurer who's down year over year. You have the big hospital operator up year over year, double digits in both cases. And then Tenet, another hospital operator with a slightly different footprint and business model. And their analysts are also looking at, single mid to low single digits for revenue and EBITDA year over year, and then 14% year over year growth for earnings per share. And so, yeah, I like it's going to be a good data point for our hypothesis around AI. And it has been fun listening to
Yeah,
these calls so far because all of the analysts ask, and everyone is like very shy about saying, like, well, we're using some tools.
yeah, for sure. That's going to be interesting to keep an eye on both this quarter and also the next year or two, how defined the use cases get and impacts we see from it.
Yeah.
So we'll see.
Yeah. Sounds great.
All right, cool. We'll catch up tomorrow.
Yep. All right. Bye.
See you, Martin.